Hi, my name is Lauren Charette, and this is my nutrition sport case study. So here's just an overview on Parkinson's disease and dysphagia. Parkinson's is a progressive neurodegenerative disease. It affects 1 to 2% of the population over 60. I've listed medical treatments and some symptoms affecting nutritional status. For MNT, definitely adjusting energy density of the diet to maintain weight within normal range. Typically, these patients do experience weight loss. You can adjust flavors and seasonings to promote PO intake. Modified consistency diets can be recommended. Oral nutrition supplements, sometimes a protein-modified diet for patients on levodopa, which is a medication prescribed for Parkinson's patients. Enteral feeding, definitely consider fiber-containing formulas. You can do pleasure feeding if it's safe, and you can also consider a post-pyloric feeding as aspiration is a common issue. Levodopa is a commonly prescribed medication for patients with Parkinson's disease. It converts dopamine in the brain, and it can just help with motor symptoms like stiffness, slow movement, and tremors. It is good to know amino acids from dietary protein can compete with levodopa to cross the blood-brain barrier. So a high-protein meal can interfere with the efficacy of this drug. There's varying degrees of efficacy, so it can't be predicted for each individual patient, but patients who do experience that on-off syndrome, it is recommended to do either one of the following. You can talk to your doctors about maybe taking the levodopa 30 to 60 minutes before a meal, or 1 to 2 hours after finishing a meal, just so there's not that competition for absorption. For enteral nutrition, depending on the institutional policy, there are recommendations to hold the feeding 2 hours before administering levodopa and 30 minutes to 2 hours after it's administered. You can also consider switching to a nocturnal feeding or a bolus feeding just to compensate for the EN being held for that drug administration. All right, so here we have day 1 of admission. He's a 76-year-old male. Past medical history and past surgical history are noted there, and his admitting diagnosis was Parkinson's disease and dysphagia. So the patient was admitted due to weakness and fall secondary to Parkinson's disease. We were consulted for a low BMI, so I completed my initial assessment on day 3. He had increased difficulty swallowing prior to admission, and the speech language pathologist performed a BDE, and she had recommended a pureed nectar thick liquid diet. During my initial interview, the patient did report fair appetite. He was eating 2 meals per day, and then per my dining report, there was a 3-day analysis of average daily intake, and the patient was consuming less than 50% of the energy requirements. He actually stated, "I've been losing weight like crazy." EMR weights were reviewed, and a 19% weight loss in 6 months had occurred for this patient. Labs were reviewed. The patient had low glucose and low phos, which was being repleted. You could see that in the meds noted there. Also in the meds, he was on the levodopa twice per day, and he was also on a multivitamin. I completed the NFPE. He did have severe muscle and fat wasting, and he had that significant weight loss, so he did meet criteria for chronic severe protein calorie malnutrition. So I completed my PES statement. My interventions are noted there as well. I definitely wanted to send him a supplement 3 times a day, educated a little bit on that levodopa if he was experiencing the on-off syndrome, ordered weekly weights, continue to supplement with phosphorus. My specific facility does use kcal per kilogram and grams per kilogram. There are no specific comparative standards for Parkinson's that I could find, but I did want to do increased needs just to sort of make up for that weight loss that he had and the muscle wasting and the fat wasting as well. So before I could follow up, I did receive a new consult for tube feeding on day 5. The patient went for an MBS on day 4, and speech recommended strict NPO due to worsening dysphagia. The patient went for an EGD and had a PEG 2 placed on the morning of day 5. Follow-up weights revealed a 5-pound weight gain since admission, so when I calculated his nutrient needs, I used his actual body weight as not to overfeed him. I recommended a standard fiber-containing formula. The fiber, again, is good for bowel movements for these patients. Water flushes are just as important to promote healthy bowel movements. Because it was a consult for tube feeding, I had delegation to order everything. And with that tube feeding being held for 4 hours with the levodopa, I wanted to make sure that he got to his goal with the pump being off for 4 hours. So instead of a 24-hour feeding, I ordered a 20-hour feeding. So this slide just shows the percent of his needs met when starting the tube feeding versus getting to his goal 8 to 12 hours later. So on the next follow-up, GI had requested to transition to bolus feeds just to prepare the patient for discharge. He had been tolerating the continuous feed at the goal rate, labs were within normal limit, the weight was stable, no nausea, vomiting, bowel movements were normal. So I did recommend bolus 1 can 4 times per day for a total of 4 cans per day. Per hospital policy, we start slow with the first bolus, so half a can, and then you go up from there if the patient tolerates. He was also on the lower end of meeting his needs, so I added a ProSource packet just to get him towards the upper end. He also fell just short from reaching RDIs for micronutrients with the tube feed, so I wanted him to stay on that previously prescribed multivitamin. And for the schedule, I wanted to make sure we avoided giving a bolus around scheduled doses of levodopa, so I coordinated that with nursing and found the times that worked appropriately. Hydration, I bumped him up a little bit to 300 mLs 3 times a day, again, just to encourage hydration. And this is just his needs that are being met on the bolus feeding. So on day 11 reassessment, the patient was tolerating the bolus feedings fine, no discomfort, no abdominal pain, regular bowel movements. He was looking really good. He had just a 1 pound weight gain, which is great. His needs remain the same, and I did discuss the current tube feeding regimen and schedule with the RD covering the rehab unit that he was going to. And then just a brief summary. So our patient was admitted with Parkinson's and dysphagia. On day 3, we completed our assessment. We had a consult. He was on an oral diet. On day 4, he did get an MBS for worsening dysphagia. Speech recommended strict MPO. Day 5, he had that PEG tube placed. We got the consult to start tube feeding. I started the Gevity 1.5. By day 8 on our follow-up, he was tolerating the continuous feedings. We were going to change him over to bolus feedings just to get him prepared to discharge. And then on day 11, patient was discharged, tolerating bolus feedings, and he was off to his rehab. So he was a really straightforward patient. He tolerated the feeding really well, and we were able to get him to that bolus regimen, which was great. And here are my references, and that's it. Thank you for your time.